Yes. مساكم الله بالخير جميعا. إن شاء الله خلال دقائق. خلال هذا اللقاء أو خلال هذه الندوة فعلنا المايك للجميع، فيا ريت تخلونا كلكم ميوت unless يعني we will open for you. عبد العزيز الشمري يمكن مفتوح المايك حقك ترى. ممتاز. طيب يمكن عشان نسهل التواصل بيننا بنخلي المايك مفتوح للجميع. When you want to talk, it's okay, and you are permitted to talk. Just open your mic. فإن شاء الله حنبدأ خلال دقائق بس يكتمل الفريق and then we will start بإذن الله. طيب just to save the time خلونا بس we break the ice and we talk to each other ونتعرف على بعض more closely. خاصة عندنا فرصة إنه عدد الحضور الحالي يسمح بالتعارف and we talk more which will indicate that we will have chance إن شاء الله to chat to each other and we will discuss different topic related to simulation. فأول شيء أحب أعرف بنفسي. أنا عبد الله عبد العزيز مرشد emergency consultant وعضو في مجلس الإدارة في جمعية المحاكاة. Currently working Fahad Medical City in Riyadh. I will be moderating this seminar إن شاء الله. يكون معنا الدكتور محمد زاهر والدكتور أحمد خبراني. بطريقة الحوار اللي بتكون إن شاء الله بتكون interactive. يمكن أساس يعني التوك هو محاضرات لكنه we will try to break it and make it interactive. We will give chances for people to speak and يعني focus on the thing that they want to talk about. Let's start with the participants or attendee, then we will move to the panelists when we start to talk. فمين حاب يقدم نفسه يعطينا اسمه والباك جراوند و what he want to us to cover today. يمكن أنا بحاول بمشي alphabetical على حسب الليست اللي موجودة قدامي. فيمكن عبد العزيز إذا حاب تعرف نفسك. عبد العزيز الشمري. طيب يمكن نحطنا قاعدة if I talk to someone مثلا 5 ثواني ما رد I will move to the second just to save the time. طيب عبد الرحمن محمادي تفضل عبد الرحمن. عبد الرحمن تسمعنا؟ طيب ندى قراوي. أحتاج أتأكد كذا إذا كان سهل فتح المايك ولا لا من البارتيسيبنت. إلى الآن 3 they could not. طيب اللي مبين لي هنا إنه معظم اللي موجودين still المايك is not permitted. just we will check this functionality before we will start إن شاء الله. طيب دكتور عبد العزيز يقول أنا أسمعك كويس. ممتاز. في ناس يقولون ما في اكسس للمايك. صفاء اذا تقدرين نفتح المايك للجميع. اللي مبين عندي انه اللي عنده صلاحيه عبد العزيز الشمري، عبد الرحمن الحمادي، ندى القراوي، البقيه ما عندهم لسه مايك. ممتاز. عجلان، تسمعني عجلان؟ عجلان الشهري. طيب دكتور عبد العزيز تسمعني دكتور عبد العزيز؟
نعم اسمع واقدر اتكلم كمان، اظن عندي المايك.
طيب ممتاز، يعطيك العافيه. طيب دام المايك it's permitted for most الى الان، باقي يمكن 2 أو 3 لسه they are working on it. ابغى اسمع من الان. It's okay while we are gathering more people to attend. You have either to use, you can use the mic if you want to introduce yourself and you want us to focus more in any specific topic from the يعني عندنا موضوعين ان شاء الله بنتكلم عنها اليوم، موضوع low cost simulation and ABC or simulation made easy. فعندنا 2 topic we want to cover. معنا الدكتور أحمد خبراني ومعنا الدكتور محمد زاهر. You can speak now if you would like to introduce yourself, or you can write it in chat. 2 ways to communicate with us. In 2 to 3 minutes we'll start inshallah our seminar. معانا مجموعة ما شاء الله من الإكسبرت، ابتداء من الدكتور عبد العزيز ووكر، معنا دكتور أستاذ محمادي، عجلان الشهري، إبراهيم البلوي، دكتور سيد فاروق. So we have a lot of people with a lot of experience. أستاذة صفاء, I think we can move Dr. Ahmed Alkhobrani to the panelist. طيب بس في قواعد عامة قبل ما نبدأ. يمكن البرنامج هذا this program you will have access to 2 CME hours provided that you attend the whole program. It will be free for the members of the society, and I think it will, if you want the CME, you will be paid if you are not a member yet, or you can join and it will be free for you. And we have every month or every 2 months 1 CME activity, part of the ongoing program that we have. First of all, I would like to thank you for joining this seminar today, and I think we can start with the first talk about simulation made easy. First, Dr. Alkhobrani, if you want to introduce yourself and your background.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
ما أعرف صوتي واضح بالنسبة لكم؟
Yes.
طيب. I would like to thank you everyone. Special thank for Saudi Society of Simulations, head by Prof. Bokers, for giving me the chance to present in front of most of you. And as you know, we'll talk just about the basic and medical simulations. And also I want to congratulate Saudi Society of Simulation for successful Saudi Society Assembly 2021 conference. So today we'll have a seminars moderated by Dr. Abdullah. My background, I'm Dr. Ahmed Alkhobrani, pediatric emergency consultant. I do my medical simulation fellowships 2017-2018, Ohio, USA, and currently practicing as a head section of pediatric emergency at King Abdullah bin Abdulaziz University Hospitals, Princess Noura Universities. So if I can share my slide, Abdullah, it will be clear.
Yes, I think So Safa, if we can move first of all Dr. Ahmed to the panelists so he can share his presentation. While we are moving Dr. Ahmed to the panelist side, I would like also to welcome Dr. Mohammed Zaher. Mohammed Zaher, if you would like to introduce yourself and your background.
السلام عليكم جميعا. مساء الخير. أتمنى صوتي واضح. I'm also very thankful for the opportunity to be part of this seminar hosted by the Saudi Society of Healthcare Simulation. I'm thankful for Dr. Aziz Bokar, the president of the society, for his interest and his attendance, and for the organizers and Dr. Abdullah Marshad for moderating this talk. I am an emergency medicine physician by training. I am the director of academic affairs in Prince Mohammed Aziz Hospital in the second health cluster, Riyadh, Saudi Arabia. And I got my simulation fellowship in Brigham and Women's Hospital, Harvard Medical School in 2018. I'm very happy to be with all of you to kind of discuss, go back and forth about maybe the concept and the ideas of utilizing a low-cost simulation neurocenter.
يعطيك العافية happy to have you both during this seminar. So Dr. Ahmed, can you tell me if you can share the slide now or your presentation, or still or you want me to share it for you?
Just give me a minute. Yes. So is it clear now?
نشوف الآن فقط الفايلز, your files, but we could not see the screen of the presentation. So maybe you're sharing a different view.
It looks. So
is
the slide.
So unshare بعدين share again.
Okay.
أنت فاتح معك البرزنتيشن ولا فاتح معك الملف نفسه؟
أول فتح البرزنتيشن. Now clear?
لا لسه. When you select the presentation, I mean the shared screen, try to select the screen that has the presentation.
So I will stop sharing and again.
بس اختار السكرين الصحيحة. Just a reminder for people who just joined, during this seminar, it will be for 2 hours, started from 6 to 8. We will cover 2 topics about low-cost simulation with Dr. Mohammed Zaher, as well as simulation made easy with Dr. Ahmed Alkhobrani. There will be CME provided for people who attended the whole program. Make sure if you would like us to include you in the CME, you write your real name in the attendee. So if you enter with different name, make sure that you put your name, actual name, so we can add you in the CME list. Thank you very much.
Here now?
Yes, we can see now, Dr. Ahmed. You can start.
Well, thank you very much. And sorry for that delays. So during these seminars, we'll go over introduction to medical simulations. We'll talk about some advantage of using simulation in healthcare and clinical training. We'll describe some modalities used in medical simulations. and we'll go about the importance of setting the psychological and safeties, outline the steps of writing simulation scenarios, and we'll review some basic steps in effective debriefing. So first of all, hello?
نسمعك يا دكتور أحمد.
So this is how we was being taught through our medical schools. And I think most of us go through these rounds. So we are going through lectures and most of universities. And we are comfortable with this, and our tutor was comfortable with this also, because it is the way how he was being taught. But recently it is found this is not the authentic environment for learning. So the learning environment and the working environment completely different. So you learn through the lectures where there is expert or tutors over the stage and he talking about some subjects. You go sometimes to the hospitals, you're practicing, just you observe things, and you don't have that a lot of chance to do full history examination and practicing, and also practicing with high acuity cases. So when you finish your medical schools and go to clinical practice as physician or nursing or any healthcare providers, this is your real environment and what you will see.
Okay, your ETA is 5 minutes with the GSW to the chest.
Help! I need help here. Get here! Who's this patient?
John, a 32-year-old male, gunshot wound to the left
In
chest.
here. Get the attending and get the trauma team.
What have we got?
We have a 32-year-old male, gunshot to the chest, BP 100 over 60, pulse 112, respiration 28. Two peripheral IVs in. 1, 2, 3.
Airway's clear.
Is the sound clear, Abdullah?
Yes.
Connection.
Scissoring him, I need to listen here.
What do we got here?
30.
Okay, let's get some blood on this guy.
7.5 too.
Let's get 4 units.
So you're practicing with many healthcare providers, and you work with the nurse, you work with the respiratory therapist, in very intensive shooting environments. And this is where you have not been taught in our learn in this ways. So medical simulations, it's give you a chance to practice in team and practice alone. So you practice with the teams, with high acuity cases, and you're practicing the skills, as we will see during the presentations. So you have the chance to work alone doing the procedures with direct and effective feedback from your mentors. You're practicing with the team, doing like CPR and ambu bagging and resuscitation, and also doing the skills that you have low chance to have it in real lives before you go to clinical practice as doing shock for a patient. So to understand more about medical simulation in healthcare, we'll go about some history of the medical simulation. So medical simulation is origin from the aviation, whereas Edwin Link, he developed the blue simulators in 1929 to train the pilot about how they can go about different weathers with difficult situations and to be taught in safe learning environment. And after that, they found there is significant reductions in the accidents when they are starting training the pilot, either military pilot or commercial pilots, before they're going for real trainings. So successes of simulation in this field allow to different discipline to have this field or simulation, especially in crowded situation or any work it has like any type of risk. So this is the Edwin Link flight simulators. You was in like cabinet of airplanes, and you are doing your flights, and they expose you to different like difficult weather situations. So you will learn in safe learning environment without giving the risk to to anyone. So after that, Rosis Annie, or Rescue Annie's, in 1960s, he's a physician. The physician, his name is Dr. Safers. He was worked with the toy developers, Lardels, to develop a rescue like task trainers. What that initially about just only about mouth-to-mouth breathing. And then later on, they developed the spring in the chest and done for cardiopulmonary resuscitations. Then anesthesia simulators in 1986, computer simulated. And then during one of the American Heart Association, Dr. Michael Gordon's, his Harvey's cardiac patient simulators. And I thought most of us go through it during the medical schools, which has like heart sound, and they have cardiac murmurs, blood pressures, and pulses. And then to develop 3G simulators, pediatric simulators. And now we have full body simulators. You can do the chest tube, you can intubate, and you can do different practice on it. That they can do blinking, it can develop cyanosis, you can listen to the heart, and he can crying and producing the tears, and he can bleed also. Also, we have virtual reality and augmented realities where you can engage to the scenarios. Also, a lot of advance in simulation for surgical field, so the physician, he can practice before he going to the ORs, and he go through the complication and how to do to deal with the complication before he going to the ORs. Also, the student or learners, they can go through it, they know the anatomies, and when they go there, they know what they have to done. Also GI scope. So after that brief about simulations, simulation, it is technique. It is not technology. It was defined by David Gaba in 2004. It is educational technique to replace or amplify real patient experience with guided experience that replicates substantial aspect of real world in fully interactive manners. So in simulation, we create lifelike medical situation and in safe learning environment and realistic event. It's controllable and it can be reproducible. You can practice it more than one time with safe technique, and you will be provided with constructive feedback, and you have chance to go over the reflective over your learning. You will learn the cognitive or knowledge. You will learn the team skills and interpersonal skills. You will go for the procedure training. So before the simulation world, it was seen C1, do one, and teach one. But now with this medical simulation, you can practice many and do after that one under supervision, and you will do alone after that.
إذا سمحت لي بس دكتور الخبراني.
Yes.
أنا ودي أعرف الآن. It was mentioned very clear that there was a moving during the history and advances of simulation. I want to understand why I need to use simulation-based training. يعني حاليا, most people, they are trained in the hospital. There is multiple options of training. We know that simulation is very costly. So from your point of view, what do you think, and why we still use simulation while it's costly? And people, they can learn from lower cost and less, sometimes modality that has less, need less effort, less resources. What do you think?
Yes, yeah, thank you, Abdullah, for these questions. Yes, so you will face this question a lot by your institution or your employers. We have a patient, why we have to go for simulations, for medical simulations? Why we have to develop simulation centers or work with institution and pay money for them to train our student in their simulation training centers. But so, as we mentioned, the learning in the medical simulation, it is self-learning environments with no harm. So you can do mistake under direct supervisions, and you will observe by the others. Also, you'd have chance to practice, high acuity procedures like intubation, like surgical airway, like chest tubes, which in real life or in clinical experience or during your training, you have limited chance to go through it or practice it.
Okay, thank you very much.
Does that answer your question, Abdullah?
Yes. Also, I would like to hear from Mohammed Zaher if he has, if you want to answer the same question, just to have different perspective. Dr. Mohammed, I would like to know why we need to use medical simulation while it is costly, need a lot of preparation, need training.
Thank you for the question, Dr. Abdullah. So it all goes back to what we are trying to measure and what are the costs of not measuring it accurately. So if we're talking in the medical field where a pass and fail decision means graduating providers that might do below standard care, which might affect patients' lives, then the question of expenses and difficulty is really worth it if simulation measures items that are not measured by other tools. So we can easily measure knowledge by questions, MCQs, oral exams, but we cannot measure advanced levels of performance. If we're going back to the hierarchy of knowing, understanding, demonstrating, and doing means practicing in real practice, then the closest step that we can get to doing is through simulation. So if we want to measure professionalism, teamwork, some competencies that are not easily measured by answering questions or a discussion, then this is the value of simulation. And in a way, and to a certain extent, it justifies some of the costs.
يعطيك العافية. And I can read the name of the participant who's attending. I know that there are a lot of experts attending today with us. So you are welcome also to answer this question if you would like, or you have a comment that was not mentioned by Dr. Khobrani or Dr. Mohammed Zaher. By raising your hand, then you can open your mic. So anyone want to also add any point that was not mentioned? تفضل أبو فيصل. تفضل.
I think the colleagues, Dr. Ahmed and Dr. Mohammed, answered very well. I would just add a few other things. Of course, the opportunity of learning. If you have one patient who needs a chest tube, you can't have 3 residents or 20 residents practice. So simulation provides opportunities that not met. Also for the safety, it's for the safety of the patient, and safety of the system, safety of the practitioners. In real life, if people do real mistake, you can't let them do the mistake and see whether they will decide and recognize and manage doing the mistakes, because all humans will make mistakes. In simulation, in real life, you have to intervene as a senior and change them and correct them and take over and then talk to them later. In simulation, you give them a chance to see whether they learn from their mistakes, they recognize the mistakes, they work with the team, whether they're arrogant or cooperative, whether they can recognize the mistake and correct them, because everybody will make mistakes. So there are a lot of other advantages of simulation that can't be replicated in real life. And these are some of the other advantages of using simulation. You cannot replace real life with simulation. and you cannot replace simulation with real life. Each of them is important for education nowadays. The same like in aviation or like any other in field training and simulation training has to supplement each other.
يعطيك العافية. Thank you very much. Now we'll go back to Dr. Ahmed to continue his talk.
Yes. So yes. So it show the improvement of competencies areas in quality research, in assessment, and in education also. So it is improve medical knowledge, also patient care, also communication, professionalism, also skills and leadership and team training. So medical simulation provides safe learning environment without risk of harming patient, provide environment that fully attentive to the learner need, and provide opportunity for repetitive training and can be adjusted according to the learner needs. So we detect this learner, he has defect on the intubations. So these simulations will be particulars for intubations or airway management. He has defect for in team leaderships. So he will work as leaderships, many and different scenarios to go and be confident leaders. It helped to enable exposure to more complex and rare clinical challenges like surgical airway. It's provide opportunity to train individuals or team of healthcare professionals. So it works in multidisciplinary trainings like code team, rapid response team, trauma team, and crisis resource management also. So simulation is needed for patient safety, for education, for training and retraining, assessing the performance of your trainee, and facilitate recruitment, improving quality of work in your institutions and in your department. And that was shown clearly during COVID-19. It will be very useful in research and evaluations, organization and team trainings. So due to increased awareness regarding the importance of the simulations and need for simulations, you can see how the numbers of the simulation centers was increased significantly. And also simulation literatures also increasing with increased awareness and increased simulation training and practice. So simulation research address there is improvement of the outcomes with the simulations, as there is few adverse event, fewer preventable incident, fewer near-miss event. There is increased efficacy of training and improve use of the resource in the institutions. So in comparison to clinical experience and simulations, so in simulation, you have structures and controls environment, and you practice more than one times. Whereas in experience or clinical training, it's unstructured, it comes accident suddenly, and it is uncontrolled. The feedback for simulation, because this simulation is set for you, so you will receive feedback about it. It is controls and structure environment. Whereas in clinical practice, you can get feedback, but it's not all of the times. So errors is valuable to learning in simulations, whereas it is errors can affect the patients, and it is unethical in clinical situations. So simulation-based trainings, the aims is move you from novice to expert with repeated practice under direct supervision and constructive feedback. So simulation and clinical practice, are they separated? Or clinical environment can be enough without need for simulation, or whether you have to practice only in the simulation and you go through without need for clinical simulation. So as mentioned by I think Prof. Walkers before, this is not the situation. They are run parallel to each others. So you have practice in the simulation, you go for clinical environment. During your clinical practice, you have some defect, you will go to simulations, you work under supervisions and with feedback, and you go to the clinical practice. So at this point, Abdullah, you have any questions before we move to another topic?
Let me clarify with all people who attended. So do you have any question, or you want to raise any point, or if you want to share also the knowledge of the group, just raise your hand. Dr. Abdez, I think this is the previous one, you raise your hand. Just feel free. I think no questions, so you can proceed.
Okay, so during your simulation training or education, you will hear by many words. One of that word, it is fidelities. So fidelity in simulation, it means to which extent the appearance and behavior of the simulation match the appearance and behavior of the simulation systems. And this is very important in simulations to provide and increase the engagement. So, okay. So fidelity can be physical fidelities, conceptual fidelities, and emotional fidelities. So physical fidelities is like moulage and environment around the simulations, presence of the monitors, crash card. Conceptual fidelities, you move from seeing it is reals to think it is reals. And that will affect your clinical reasoning and prioritization of the management for their patient or the scenarios. Emotional fidelities also, so that is the emotions in the scenarios, it is enough to affect your decisions and affect your decision and management of this patient. For example, you are doing the CPR for a pediatric patient, for example, and you see the mother or the actor or confederator, she's crying. So now you will stop the CPR. It's more than 20 minutes or 10 minutes, or you will continue the CPRs. So it is realistic as you are in the clinical situations. So it can be used in the peri-hospital settings. Medical simulation, it was being used effectively during COVID-19 and here the intubation box, and testing the systems and testing the pathway in the institutions, and making the disaster plan also. It can be helpful for task trainers. You're doing only the procedures and high acuity procedures with less time or less chance to practice it or exposure to it, especially with increased number of the trainees. So now the number of trainees in the medical school, they are increasing and they have less time to practice and less chance to expose to the patients. So simulation field can be one of the situation that help them to get exposure. So it can be hybrid simulations. We're mixing both task trainers with the real patient to get more emotions and it's more realistic. So if you are doing suture on patient, real patients, so she will act like she has pain. How you will talk to her, how you will communicate with her, and how you will get consent, how you will take decision about analgesia. And for examples, for this pediatric patient, he has like amputated legs, which is only moulage issues. So you will prioritize, I need to stop bleeding first, or I have another patient, he's like cardiac arrest, I need to go for him first, which one more stable. So this emotion will affect and your decision making. You have also the wet labs, which is you will provide you a chance to go through anatomies, sutures, nerve block. So simulation can be used in the ambulance, in the airplane, emergency department, operation rooms, critical care, and hospital ward, and also in pre-hospital settings. So before, as you hear frequently, practice make perfect and permanent, but what is termed to be only supervised practice with constructive feedback make perfect.
Yeah. Just I have a يعني let's clarify موضوع fidelity. You know, the fidelity, maybe we make it something very simple, and sometimes we can make it very advanced to make it as realistic as very close to the real. So why we need to do this? Do we need it all that? Do we need it sometimes? Is there any specific objectives that we need? Sometimes we need to use it for that.
Yes. So fidelity it is commercial word. It's used by the simulation company most of times, and fidelity is very important for making it is more engaging and increase interaction and between the team and to work on it as it is serious situations, and they dealing with it as they are dealing with the real patient. So, for example, if this patient is smiling and he is talking, while this is with the moulage, if it is bleeding, so this is unrealistic for me as a trainees. But if he's screaming, it will show me this is more realistic. Bleeding, he is screaming, so he will increase fidelities and will increase engagement and increase of the work between the teams, as this is more, we'll take it as serious and we'll take it as real as we can.
Even this patient, if he's, let's say, smiling or crying, if I want them to manage, let's say, the situation during disaster, or they want to control the bleeding, do we need to make him he's a pediatric and we need to instruct him to cry, or just we focus on the big picture? And it will take a lot of time to educate this kid how to act in the scenario. Do we need to invest this whole effort on this?
Yes, as you mentioned, I think from my view, it is depend on what is your goal and objective for this scenario. Is your goals and objectives to see how they are work when they are see the emotional thing like this, or how they are brutalizing their management, or how they are communicating with the patients. So fidelities, moulage, making environment as realistic as we can depend most of times what is your goal, what is your objective of the scenarios. And we can hear from Dr. Zaher also if he has.
Dr. Mohammed. وبعدها we'll take one from the participants. Mohammed, you are mute أعتقد. The question is, do we need to increase fidelity all the time, or we need it sometimes, and when we need it?
سامحني معلش to mute. I will tackle this question specifically when I talk about local simulation, but the short answer is it depends on the objective. Some modalities or some implementations, some objectives do not require high fidelity per se. It is good if it's there, but it doesn't increase the learning outcome. And this is related to some evidence that exists that I will talk about in my talk.
Thank you, Dr. Mohammed. If someone also wants to share his thought from the participant, we'll take one now. Feel free to raise your hand and to speak. طيب يعطيكم العافية جميعا. Let's move on, Dr. Alkhobrani, to the next point.
Yes. So now we'll move another important aspect in the medical simulation, which is physiological safety and physiological safety. So physiological safety It was defined to be a perception of the consequence of taking interpersonal risk in given group context. So it means when the learners, he feel free to speak his mind without fear of imprisonment or being judged or punishment. And he feel of the mutual respect and trust among the team. And this is very important for effective team interactions and teamwork, and also for effective debriefings. And it's occurred through all through the simulation scenarios, before the scenarios, during the scenarios, and also during debriefing. So this is some tips to maintain psychological safety during simulations. So you need to welcome your participant into the simulation space and initiate team buildings. Each one he is present himself, what his background. So you will break the barriers between the participant and faculty and instructors, and also between the participant themselves, and start building a team. You need to set the objectives from the instructor aspect and the objective from the learner also. Set the ground rules early before the starting simulations. So respecting each other's, and also emphasize on positive feedback, and avoid criticizing each other's, and show mutual respect to each other's. Show some logistic rules regarding what is the foods to the environment, playing area if needed, and keep them familiarized with the physical environment and familiarized with the equipment if they are practicing for the first times or they are coming for different scenarios. So that will let him, it's more engaged and more comfortable to practice. Maintain confidentialities, and this is very important aspect. What happened in the sim, stay in the sims. We are not talking about each other's. We are not judging you. We are not talking about what you did here, and each other, they are not talking about each other when they go back to their institutions or to their hospitals or clinical work. Basic assumptions, and what is very important to share it before and show it during the clinical practice, not only just a word you inform the trainee about it. You need to show during the practice. Each one is he has knowledge, he can by himself, he need to learn, and we learn from each others. Fiction contracts, and that also what we talk about it in Fidelities. So this is simulations and patient simulators. It's made of many mistakes, and it will not be realistic as real clinical practice, but we deal with it as we are in clinical practice to get more benefit. Avoid cognitive load, which is if there are many informations, many things, and many objectives, it will overwhelm. When you say it's overwhelming the trainees, you need to decrease the information and focus on the most important situations. You need to talk about it. Identify there is if any one of the trainee become distressed or he have intense in simulations, so pay attention to that and act accordingly. Communicate with respect to the learners, understand their perspective, and respect their opinions. So if they share something, you have to listen to them and respect them. So emotion is very important.
Dr. Ahmed, so if you allow me,
Yeah.
Are we exaggerating the importance of psychological safety? We know that previous teaching methodology that was very effective people, they are not considering psychological safety. They are taught by, let's say, by observation, by role model. We have good role model before, and still, but why we need psychological safety? Why in simulation psychological safety? We know that during the in the clinical rounds, no one taught us about psychological safety. Why in simulation?
Yes. So in simulation, yes, it's very important aspect because you need. So we are not judging what they are doing, or we are not talking about what they are doing and what the result of their doing, as we are not going or understand what their frame and what are in their mind. So if you need to maintain the psychological safeties, because this is the core of your simulations. You need to know what is in his mind, which is you will, as you only see the actions and the result of that action, but you don't know what is going there, what is the emotion, if they have previous experience with that. So if he feels the psychological safeties and he feels they have respect between the teams and there is trust among them and there is basic assumptions as seen and from the instructors or from the educators, he can express what he is in his mind without fearing of being punished or judged, or he is impressed.
Okay, thank you very much. So what I understand from you, Dr. Ahmed, that preparing the psychological safety will allow people to share their thoughts in safe environment, and this will help to each other to help all practitioners to understand each other. Is this what you are mentioning?
Yes.
Okay.
And, yes, and will help you for rephrase and rephrase your trainees.
Thank you. Same question, Dr. Mohammed, and we will talk one from participant also. The question was, are we exaggerating the importance of psychological safety? The previous traditional thought was not considering the psychological safety as we are speaking right now, especially in simulation. If you want to share your thoughts, Dr. Mohammed.
I argue the way that we understand teaching and education is changing. So we used to do a lot of things differently 30 years ago in medicine, in education, and in a lot of other fields as well. So I think that the concept of psychological safety and well-being of the trainees is an evolving concept that the focus has shifted to recently. But I think the focus on psychological safety extends beyond simulation at this point of time. Maybe it's more important in simulation because we assume that the learning happens during the debriefing. So the learning does not happen during the actual simulation. Most of it happens during the discussion that follows the simulation. And if people are not having a two-way discussion, then there is no difference between a simulation and a lecture. Maybe that's why it was a cornerstone of scenario-based simulation. But I believe that the safety of the trainees is becoming more important in education overall.
Thank you very much. Let's take one more comment from our expert who attended this session. Dr. Abdulaziz.
I think this is a very good question because as the speakers mentioned, Dr. Ahmed and Dr. Mohammed, that world is changing, learners are changing, the demand for learning is different, but also what's different between clinical simulation and simulation or training in clinical environment is that in clinical environment, usually the discussion is more on feedback. So I tell you what I saw, and then I will tell you what are the good things, you know, like we will talk about the good things that you did and the things that you could improve. But in simulation, as Dr. Mohammed and Dr. Ahmed said, that debriefing is when you help the learners as an instructor to think deep about their state of mind, their frame. So you need to go deeper and deeper. So it's actually exposing themselves to the discussion and helping the learners and the other learners to analyze why did they do what they did and how they could improve it in the future. So there is more psychological exposure. So they have to speak from their insights. They have to talk about their experiences, not only what happened during simulation, but what was happening on their mind. And it is very deep discussion. For that deep discussion to occur in a safe environment, they have to know the secrets are kept, the learnings is enhanced, but no secrets will be going out because they will have to expose their thinking mechanism. Maybe some of them are right, some of the thinking or the facts or the conclusions or previous experiences were not as good as they would like. So there is more psychological exposures in simulation because of the debriefing and the deep learning that's happening. And that's why it's very important, more than it's important in clinical environment to have psychological safety, but in simulation with debriefing and the deep thinking, it becomes more exposure. And we have, as instructors, administrators, accreditors, we have to make sure that psychological safety is agreed on, maintained, implemented, reinforced, and reminded of all the time.
يعطيكم العافية جميعا. Let's go back, Dr. Ahmed, if you want to proceed now.
Yes. So control of emotion during the simulation scenario is very important. So you need to keep your trainee is pleasant and activated, alert and excited during the simulations. Because if it is go extremes, tense and nervous, that keep them unpleasant. And if it is you are teaching something they are know and in environment that not engage them, they will be relaxed and deactivated. So during simulations, you need to keep them alert and excited and activated, whereas during debriefing, you need to go back to keep them pleasant and comfortable. And they are safe to expressing what they are going on in their mind. So now we'll go about, in brief, we'll talk about simulation scenarios. So it is the four important point in writing simulation scenarios, how to choose the topic. And choosing of the topic for simulation scenarios depending on your learners, what the learners and what their need. And that's depending on the pre-assessment of your trainees. Who are your trainees? If they are undergraduate, if they are postgraduate, if they are working in clinic and critical situation like ICU emergencies, or they are working in the operation rooms. So you will pick the topic based on your trainees and your need. And then you will design the learning objectives and the overall outcomes of your scenarios. And then you need to have assessment plan for the simulations. So for successful simulation scenario, you need educational goals and objective, intended outcomes by the end of the scenarios, critical actions checklist, and that have to be done by your trainees with these patients. And it is important in your scenarios. Setting of the simulations, it's very important. You need to understand what setting of simulation you have. So this simulation will be in situ simulations, in ER, in ICU, in the operation rooms, what equipment you have there, or it will be in control environment, like in the simulation centers. What moulage do you have? What simulation technician you have there. So you need to think about each aspect before you go through your scenarios. And then to make narrative for your cases and the design scenario flow diagrams with branch point, instructor's note, and to have debriefing plan and objectives, what you need to debrief from these scenarios. And if there is something raised, you can talk about it during the scenarios. So for setting the goal and objectives, keep it as smart, specific, measurable, and attainable, realistic, and to be achieved within time limit. Structure the simulation to have defined start point and end point. And the start point of your simulations, you need to think about it. From where the scenario was started. It is started from, like, for emergency, from the triage, or code will be announced in the ward for this patient. This patient will collapse in the corridors. So you need to define what is the start point for your simulation and what's the end point. And to keep your all teams on one page with you. So each one, he know the detail of your scenario from your team who is working with you. Will the learner, and then how the learner will go through it. You will announce the code so the learner will go through it, or you will ask them to go immediately to the resource rooms. So how the learner will go to and start the simulations scenarios, and and you need to keep what the steps they need to do and solve the puzzles to go to achieve the outcomes of these scenarios. And time limit for your scenarios is very important, usually from 10 to 15 minutes maximum. And the end point of the simulations is the times out, or they achieve the preset objective and intended outcome. So develop the process flow map and what event will trigger the scenarios. So what action they will do, and did they need to do the procedures, like did they need to insert the IV line from the scenarios, or just act and they will say for them considers done, or did they need to insert fully CAD and this is objective of the scenarios, and what the aspect they will show when they are doing the actions with the scenarios. They will show the blood pressure is improving, or they will show patient become hypotensive, or the patient Glasgow Coma scale will come down, so he is not responding anymore. So you need to know what the event will trigger the scenarios and what the action will be they will see in the simulators. And what does the patient look like after the interventions? And this is the flow diagrams. You need to design the start point and end point. So here start the point, for example, from the triage areas, and then registrations, and patient go to after vital sign, he will go to the resource rooms, or he will go to the rooms, and then decide what actions well done, critical action they need to do. And if they didn't do that critical action, what is the status of the patients? And you need to think about all the aspects you needed to achieve and solve the puzzle to reach the outcomes, which will end it by, like, for patient was admitted to the ICU, or the patient was transferred to other hospitals based on your objective of the scenarios. So what the patient status, what action taken, and if this action is not taken, how the patient will looks like. If they take different action, how the patient looks like. And if they take the critical actions, which one of the objective of your scenarios, how's the patient is, he will resolve the status. And if they didn't take the critical actions or action they intended to do, they didn't know, is the patient will crashing? So you need to think about all this while you're writing the simulation scenarios. You need to work with the simulation technicians, decide about fidelities, what fidelity you need to do, what moulage, how to be realistic, Develop the script and checklist to outline the objective of the scenarios, what equipment you need to know, what information will given to the learner before and during the simulations scenarios, how the image will appear, how the labs will be shown. If they need to communicate with someone like ICU or toxicology or trauma teams, how this will go, this will be done during the scenarios. And create patient chart, it's very important. And close the scenario when, as we mentioned, when all goal or objective was attained or time out. And allow time for debriefing, which is considers is the most important part of the simulation scenarios, to express about what run in their mind. Dry run is and rehearsal is very successful way for successful simulation scenario sessions with all your teams, and expect what thing it can be or errors or something will be missed. It can happen, so you can solve it early before it's happening. And this is example of the one simulation scenarios. It takes times, but you need to go all over the steps. And this is one of the disadvantage of the simulations is when you are writing the simulation scenario, writing simulations, it needs a lot of preparation and I need a lot of times. And you need to put all the image they need. If they need like CT scan, ECG, what the lab they expected to ask about it, you need to have it, to keep it, it's more realistic. And also the briefing plan need to be ready. So this simulation, even if not run by you, or you are not around any other, he read your scenario, it is clear for him, and he can run this case for successful simulation scenarios. So Abdullah, do you have any point before moving to last talk in our seminar?
Yes, please. Just I would like to get, طبعا احنا دخلنا في موضوع السيناريو development and how to make it successful by proper planning. Just if let's see, now we know the process. I would like to get your experience and advice to how to make the scenario in general easy, successful, easy to be implemented from your experience, from the scenarios that you developed before, how to make it successful.
So yes, so the successful of the simulation scenario is depend on pre-assessment of the learner and pre-assessment of their need. So who's your learner and what they are need, okay, and what their levels. So if you are working with like for example for pediatric emergencies fellows, and you present for them something cases like controlled bronchial asthma, you are wasting their times. So you need to present for them something attractive to them, and it is beneficial for them, challenging to them, and but is not extreme challenging, can be solved. And they will get lessons, and they will go home with some messages from these scenarios. So after you get what they need your trainees, now you will go for the scenarios. Better to link it with the stories or the scenarios, real cases that you are you have faced or exposure, you hear about it. So you link the scenario with the case similar to what you will present, and then you go over the what critical action, what is the critical in this case, what must be done in this case, and not need to be lost. And this is based on what is the objective of the case. Then you will go over the branch, you write the scenario, the histories, physical examination, and go to for the branch point for the scenarios. As we mentioned, through the flow diagram. It's very important, the flow diagrams, to expect at each stage, when patient presented, when the patient is this action taken, what his vital sign, what expected action to take, if not that be done, how to be solved it, or how the facilitator can interfere, and it is give guide, or the nurse inside will give him guide for this. So they will go in the correct track for the patient for the scenarios, and try as much as possible not to put a lot of phases of the simulation. Keep the phases with times to be finished within time limit. And then to end by to have the image and to have the labs that is needed. And if they ask for any service, you already prepares the service that you needed, like backup ICU, ANT, anesthesia, or who you need from there. So you have specific objective for this scenario. You have specific action. What is the most important? You imagine what it will be run through the scenarios, and then you have what they expected to ask about it. And then if they need help, you already have the backup for this help, and they will provide guide according to the objective. For example, like communications with ICU or communication with anesthesia. And we'll end for the debriefing. End of the scenario, and you will go for debriefing. So already you have the debriefing plans from the scenarios.
يعطيك العافية دكتور أحمد. Before I will also ask the same question, Dr. Mohammed, which is the, let's say, golden advice related to simulation scenario. I will also invite our sim technologists who attended this activity. Also, I will ask you soon, what is your advice for, let's say, educators who want to prepare scenarios, how to make it easy for you to run it, etc. Dr. Mohammed, your golden advice.
My golden advice, so my advice for building a scenario is show it to somebody else before you implement it. A lot of times we can be under the impression that the scenario that we created is perfect, but then when we get someone from a fresh perspective who looks at it and imagine how it runs, they can identify issues that we didn't think about. So remember that you're trying to emulate real life, but in a simulation room or with a mannequin in an in situ implementation. So a lot of things might seem easy and taken for granted when you're writing it down, but the interaction between the learners and the environment can necessitate that you add a lot of different aspects to the simulation, like a time limit, for example, or the instructor talking to the learners because there is a functionality that is expected in real life that will not be happening with the simulator. So anticipating these events and writing them down, and especially asking for somebody else's opinion because they can imagine these things sometimes from a different perspective is really helpful.
Thank you very much. Now from our attendee, I would like to hear a perspective of an expert sim technologist or sim operator. What is your advice to make it easy to run for a scenario development? يعني الناس اللي اشتغلوا كسم technologists or some specialists before, your opinion is very important, especially to make, sometimes we can develop scenarios that it will be branches in a lot. So do you have any advice for people who want to develop the scenario? نبغى نسمع أصوات جديدة. طيب ما في مشكلة. يبدو انه لسه ما في اي كومنت. خلينا نتاكد من الشات اذا في احد علق على نفسه. طيب محمد تفضل يا محمد. محمد go ahead, just unmute yourself.
السلام عليكم.
وعليكم السلام ورحمة الله.
يعطيكم العافية. بس بما انكم تكلمتم عن الهيستوري اوف سيميوليشن وتكلمتوا انه كانت بدايته عن طريق الميليتري او الافييشن، بما اني يعني military medical simulation instructor وسبق لي جربت السيميوليشن في الميليتري. تكلمنا عن psychological safety وانه كيف التريني دائما ما تحطه اندر ستريس، انه كيف يعني he will lose a lot of skills، يعني كيف المسل ميموري عنده تتغير بشكل كامل، حتى لو كان يعني before 1 hour he did the same skills very well، بس لما تحطه under stress he will lose his muscle memory. just I want to add this point for stress إن كيف إنها يعني إنها مهمة في عملية ال simulation learning. That's it.
يعطيك العافية، شكرا على إضافتك محمد، ما قصرت. If we don't have any more comment, we'll proceed to the last part. طيب go ahead يا دكتور أحمد، تفضل.
Our last part is debriefing after simulations, which is considered the cornerstones of the simulation and the most important part to get the knowledge and to think about what's happened and how to improve it next times and home message from these scenarios. So I think all of you go through these cycles, which is very important in medical education cycles, it is experiential learning cycles by cycles. So you go through the simulation scenarios, or you go through the experience, and then reflect what happened in that scenarios. And then during debriefings, you think what happens and why I did like this, and if it's happened again, what I will do against. So you practice, you observe, you go through it, and you hear the feedback, and you understand what is the right, and you are reflecting what you did and how it happens, what you will do next times. And then you will now you have the concrete experience, and you can practice with new frames and new knowledge and new competent. So it's happening after debriefing. So debriefing is a conversation between two or more peoples to review a real or simulated event in which participants analyze their actions and reflect on the role of thought process, psychomotor skills, emotional status to improve or sustain performance in the futures. And this debriefing can be in the medical simulation, and also it can be in the clinical practice. So why we are doing debriefing? So it eliminates learner feelings and allow to them to express their reactions. And it leads to modification of the attitude, acquire new knowledge and skills, change in the behaviors before the scenarios and afters, and that will carry with you to the clinical practice. Your practice will be changed, and finally the patient outcome will be changed and improve positively. So during debriefings, we discover the gap in the knowledge. We discover what the gap defect between the actual performance and the desired performance. And we go through it to complete and fill these gaps during debriefing. So you have your frames with knowledge, with feeling, and situation awareness. And based on that feeling, you do your actions, and that lead to the result. What we see is the result based on that action you did, but we didn't know what is your frame, what is running in your mind. So when we are doing the discussions or debriefings and interactive discussions, now we know what is your frames, and reframe your thought, reframes your feeling, reframe your knowledge base, and that lead to new actions and new results, and that lead to the concrete experience which you will carry with you to the clinical practice, or when you run this simulation scenario again. So we are talking about what we are debriefing about: the team dynamic, communication skills, team leaderships, situation awareness. So there is many technical and non-technical skills you need to talk about during debriefings, and anything you notice during debriefing, during the simulation scenarios, and you need to clarify more. So if it is a lot of things, it's running there, you need to prioritize what is the most important for their learners and for the objective of the learners. So you go through it. So debriefing allows trainees to explain, analyze, and synthesize information, emotional state, to improve performance in similar situation in the futures. They are sharing critical judgment, an essential part of learning in simulation and debriefing. So there is a lot of framework of the debriefings, and most of you hear about it: debriefing with judgment, with no judgment, debriefing with good judgment, and for a event of debriefings, gas for debriefings. So all it's all it run through 4 phases, different frame, but it's run through 4 phases: reactions of the learner, descriptions phase, what is gone through, what is the scenario, and what is done for this scenarios, and then you go through analyze, and then you select how you will debriefing ways based on how much time you have, what is the rational and evident, is there is any is it just the knowledge, or you need to talk about content areas, you need to talk about the teamwork, team what is the briefing way you will use. Last we will go through the
خلاص أنا 20.
عفوا أستاذة نسرين عارف المايك.
Or you will go through advocacy and theory corrections, and then summarize the summary from the objective of the instructor, and in conclusion, simulation training will become an integral part of everyday training and practice in the field of medicine. Simulation is technique to replace or amplify real patient experience with guided experience. Simulation increase patient safety, accelerate trajectory of the for practitioner, debriefing with good judgment. This is the end of my talk, and if you have questions, it's open.
نسرين بس المايك يسد. تفضل. دكتور أحمد.
Yes.
Okay. يعطيك العافية. شكرا لك دكتور أحمد. Now we will move. Do you have anything before we will move to Dr. Mohammed?
No, this is the end of my talk.
خلاص ممتاز. يعطيك العافية. شكرا لك. Now we'll move to the second part, which is the low-cost simulation with Dr. Mohammed. Mohammed, you can share your screen.
Thank you very much, Dr. Abdullah. Just a second. That's unusual.
طيب.
It's being ready. Just a second.
طيب فيما يبدأ الدكتور محمد feel free يعني 1 minute ولا 2 minutes stretching stand change your position. احنا نعرف انها 2 hours فممكن نحتاج واحد كذا يتحرك في مكانه.
قاعد اتعلم شيء جديد من الاوبشنز حقت الشيرنج في الويبينار is different من الاوبشنز حقت الشيرنج في شو اسمه في البرزنتيشن العادي. كذا اللي باين هو هل باين البرزنتيشن ولا الباوربوينت نفسه؟ دكتور عبد الله.
البرزنتيشن محمد.
باين البرزنتيشن ونو بادجت نو بروبلم ونايس كار.
الله يعطيك الف عافيه. ثانك يو سو ماتش بروف بوكر والجميع. طيب ثانك يو فيري ماتش. يعطيكم العافيه جميعا. So just a reminder, my name is Mohammed Zaher. I'm the Director of Academic Affairs and Prince Ahmed Al Hospital. I'm going to be talking about low-cost simulation. The title of my presentation is No Budget, No Problem, Introduction to Low-Cost Simulation. So let's start by declaring that I have no conflicts of interest to report. During the next 30 minutes, we're going to be trying to understand what low-cost simulation is. We're going to be comparing the validity of low-cost simulation modalities to high-cost alternatives. We're going to justify several use cases for low-cost simulation modalities, identify some challenges to implementing low-cost simulation, and develop a mindset for establishing low-cost simulation activities. So let's talk a bit about the background. In the pictures here, you're seeing my colleague and fellowship partner, Dr. Abdulrahman Sabbagh, trying out a prototype of the first low-cost simulation model that we worked on together along with Dr. Luay Soleimani. This was a project that we worked on during our fellowship training, and it ended up being utilized both in Harvard Medical School in teaching the emergency medicine residents, and in Saudi Arabia as well in teaching residency trainees how to do close reduction of shoulder dislocations. I was pleasantly surprised by the feedback that we got about this product. But in reality, this was not the end goal. The end goal was not to make a model so that we can show it to people and be known about it that we made a model for shoulder reduction. It was basically the combination of the need to train. We wanted to address a gap in the literature about using simulation to teach procedures. There was no reported use of simulation to teach close reduction of joint dislocation. And we were willing to experiment. We didn't find anything in the literature describing a model. So we sat down and looked at the available functions that we wanted, looked at the available materials that we had around or that we could order. And we started from there and we ended up with that product. And since then, I've been very interested in pursuing further low-cost simulation implementations. And teaching, making them and teaching them as well. So when we want to define what low-cost simulation is, I think when people hear the word low-cost, they think of a lot of things, and sometimes what they think of is what we mean by low-cost simulation, and sometimes it's not. So I think a good starting point would be for us to understand what low-cost simulation is. We might want to start with understanding what low-cost simulation is not. So low-cost simulation is not devices, is not models. It is not a couple of recipes that you're gonna make and then you're gonna have a low-cost simulation center or training environment. It's more about the concept. So you have a set of keys, or you have a set of skills that you will utilize to answer specific challenges or specific implementations. So you're basically trying to make a balance between the training needs that you have. So I need to teach this procedure. I need to teach this scenario. I need to recreate this environment, but I do not have the luxury of affording a commercial product for it. Or maybe, as you're going to find, there are other reasons why you might have that need, but you might want to develop a low-cost alternative. So it's that balance between the need and cost that kind of sets the stage for the utilizing low-cost simulation techniques. And that goes beyond just creating a model. So you have multiple pathways that you can reduce the cost of your ongoing simulation program, or developing a new simulation program that are that go beyond making mannequins. You can purchase alternatives to the very expensive commercial mannequins. You can find other commercial mannequins that are much cheaper. You can buy used mannequins instead of buying new ones. You can augment mannequins that you already have that have a specific functionality. You can augment them by adding other functionalities that did not exist before. And in the same way, you can repurpose mannequins that were used for a certain set, but they're not used for that certain skill anymore. You can reuse them for another implementation. For example, if you have an airway mannequin that you're not using anymore, it makes a perfect dental anesthesia mannequin. It has the exact anatomy that dental learners need to practice dental anesthesia. And finally, you can create mannequins out of scratch. If all these above options do not answer your question, then maybe you want to create something from the ground up. The second point is that low-cost simulation is not zero-cost simulation. There is still a cost. Even if it costs you zero to make, then there might be even opportunity costs or time costs that you're spending. And when you're making a model from scratch, and especially if you're prototyping, or you have an idea, but you not have a specific recipe and you're trying to work towards a recipe, the prototyping costs money. But the general principle is it's going to cost a fraction less than buying a commercial mannequin. And let's talk about some examples. So these are two NRP mannequins. So one of them is a little bit more expensive than the other. Let's take a moment. Let's take a minute to try to guess which one is more expensive than the other. Dr. Abdullah, وش رأيك? Which one do you think is more expensive?
والله أعتقد اليسار.
اليسار is more expensive. You're absolutely right. But do you recognize by how much? So the one on the right is about 2,000 riyals. The one on the left is 82,000 riyals. So I would assume, since the one on the left is 20 times more expensive, it should be better than to teach NRP. It should be 20 times better in teaching NRP. Is that right? No, it's wrong. This has been scientifically proven that if you get those two mannequins and you randomize people to one of two groups to teach NRP, you actually get no difference in their written tests. You get no difference in their hands-on or practical tests. And if you test them 2 months later in their NRP skills, you find out that they do exactly the same. And that leads us very nicely to our next point. When we say low-cost simulation, we do not mean low-fidelity simulation. And we've talked about the concept of fidelity in the previous presentation. And to sum it up, and I know my statement is wrong to any simulation expert here, but if I will talk about it in 10 seconds, fidelity is basically how much the product that you're simulating resembles real-life performance. And it goes much deeper than that, but let's keep it at this, for the purpose of this presentation, let's keep it at this definition. So when we say low cost, that does not necessarily mean low fidelity. And the reason is fidelity is task specific. And let's take a moment here and elaborate on that. So you can, I'm sure if anyone of you has worked in a simulation center, they've been exposed to SIMMAN 3G. It's the most commonly used high fidelity mannequin in simulation centers, as far as I know. It's called a high fidelity mannequin because it has multiple functions that we can utilize that resemble the performance of a real human being. But can you insert an interosseous line in the mannequin? Not always, and not necessarily. So let's say you can intubate the mannequin and it is very close to real life performance, then the SIMMAN 3G is a high fidelity mannequin for intubation, but it's not a high fidelity mannequin, for example, for interosseous placement or central line placement. So fidelity is not attached to the mannequin or the device, it's attached to the function that you're trying to interact with the device with. And on that purpose, if we go back to these two differently priced mannequins, for the function of practicing NLP, there is no difference, despite the price tag. And we can go through more examples of that same concept, where low-cost modalities have done the same performance in that specific implementation as much higher costs models. So in Rwanda, healthcare providers were utilizing BLS mannequins to teach anesthetist non-technical skills. So these mannequins did not have vital signs, did not have a heart rate, etc. They only had an airway. But the implementation or the use of these mannequins led to a significant increase in the non-technical skills scores, when you, which is a validated instrument to measure non-technical skills. So they had a recorded valid improvement in their skills when utilizing low-cost mannequins. And the examples keep going. Using low-cost simulation in training training emergency residents in pediatric station, it led to a significant increase in their self-efficacy and their competency. If you can identify what's in front of you in the picture, this is basically a wooden plank with shoelaces wrapped to it. You certainly would not imagine that this would be used to teach people how to do ACL, anterior cruciate ligament repairs. So that's a complex surgery that's sometimes done under that's done through a scope. But when using that model to train residents to do it, they had significantly improved performance during the actual OR. And when you go, for example, from the ENT specialty, people have made pipes to resemble the nasal turbinates. And when residents were trained using that model, they had a significant increase in confidence. They had a patient-related effect, and few studies measured that. So there was a significant decrease in patients' pain scores for residents who were trained using either the low-cost or the high-fidelity model or the high-cost model, but there was no difference in performance between the low and high-cost trainers. So I hope I've convinced you that low cost, when implemented correctly, when we understand the guiding principles behind it, it is a very effective modality to teach. But most people are here because I would argue that they're here because their center does not maybe provide them enough budget, or their institute, to start a center, to start a simulation service with fully commercialized mannequins. But that's just one of the reasons why people might want to go for low-cost simulation. So, and there are a multitude of other reasons why people would go for low-cost simulation. So let's say you're just starting, you're in that phase, and you're asking for your 10 million riyals to start your simulation center. You might want to start small. You might want to make a proof of concept. Hey, look at this, look at how I'm implementing it. And if I can achieve that outcome on a smaller scale, imagine how much I would be able to achieve if you give me that 10 million. And a lot of the simulation equipment that we used are very heavy. We cannot move them outside of the simulation centers easily. And if we want to make a simulation that is in another venue or another city, then sometimes we want to bring our equipment and assemble the models over there. And you might have in your center 1 airway mannequin, 3 airway mannequins, 5 airway mannequins. But what if you need 20 airway trainers? What if you need 100 airway trainers for whatever reason? What if you're doing a community work that spans multiple places that has to go concurrently? So even if you have your commercial implementations, sometimes you cannot scale it quantity-wise enough to meet the demand. So you're going to have to augment your commercial servers with low-cost simulation implementations. And one of the most beautiful aspects about low-cost simulation that you can actually use to augment your existing mannequins is that you can scale the fidelity as you want. So this is a surgical airway trainer. This is a picture that's taken from the internet for a low-cost implementation of a cricothyroidotomy trainer. So that's basically ventilator piping with two tape rolls that you can make an incision in between and insert a tube. But then you can cover it with some tape and kind of let your trainers go through the skin. So that kind of adds a step that kind of a little bit comes closer to what they can do in real life. You can take it and instead of like just having the pipe as it is, you can use clay, and this is our implementation of it. You can use clay to kind of simulate the normal anatomy, the normal cartridges, and that open it for the cricothyroid membrane. So when they palpate, they can actually feel the anatomy in a way that resembles what they would feel in a real patient. You can add an airway mannequin around that, or you can not an airway mannequin. You can add like the anatomy around that. So you can add a face, you can add shoulders, where people can actually kind of orient themselves into where they're gonna go. So now they can actually stand in the same way that they would stand around the patient. And when you've done all of that, maybe you want to add an IV bag with that's dripping blood, so they can, while they're doing the actual procedure, they can kind of face a little bit of a challenge. They would do it in a bloody scene. So all of what I've talked about is a surgical airway trainer, but they span multiple levels of fidelity, and you can scale that fidelity in any implementation that you do based on your needs. And finally, as with that shoulder reduction mannequin, this was sometimes you're going to find implementations where there are very few commercial mannequins for. In this is a model that we made for a course for residents. It was an ultrasound guided pericardiocentesis model. Again, we could not find a pericardiocentesis model that you could ultrasound. So we had to come up with that need. Was it perfect? By no means it was not, but it was something that was not commercially available at that point of time. So sometimes your lab or your low-cost simulation service can actually answer needs that the commercial companies cannot. And finally, it is a very nice way of getting publications, patents, and awards. This is Dr. Arwa Madani, one of the people who were working on that pericardiocentesis model. She presented, she was awarded the Innovation Award in the 2019 Simulation Conference for another model that she made. So again, it's a continuous stream of research articles, awards, and patents if you're interested. Maybe that's a good time here to stop and take maybe some questions.
طيب يعطيك العافية دكتور محمد. Thank you very much. So let's ask the attendee if you have any question to Dr. Mohammed. طيب إذا ما في question, just I would like Mohammed to share your experience about commonly used low-cost solutions. يعني from your experience or that you saw before in your center or other centers.
Thank you, Dr. Abdullah, for the question. So commonly used is very discipline specific. So I am an emergency physician. I use low-cost models that teach emergency medicine techniques. So from my experience, we've used the shoulder reduction model for in the ortho block. It involves shoulder, elbow, and small digit dislocations as well. So we use it in the orthopedics blocks to demonstrate the techniques of close reduction for these injuries. We have used that surgical airway mannequin in teaching senior residents life-saving procedures. So this is a very rare procedure that they need to do an emergency cricothyroidotomy. So I've done my first one out of my residency. I've never seen one in my residency. So it is useful for them to kind of get that muscle memory of where they're going to be sitting, what they're going to be doing, the steps, so they can implement it when they see their first patient. We've also used vascular access mannequins. So we've created in-shop ultrasoundable vascular access mannequins that we use to demonstrate central lines, peripheral lines, etc. And the good thing about these is that we can remelt them and remake them again because the phantoms or the commercial mannequins, if you're inserting a central line, you cannot do dilatation in these mannequins because otherwise they're going to start leaking. But the ones that we made in shop, we can reuse them over and over again, and we can like do the full procedure from beginning to end because of that reusability factor. Also, we have made a neonatal umbilical access or umbilical venous access model that we've used during the pediatrics module as part of the NRB training, just in case they needed to obtain vascular access through the umbilical cord. I can go on, but let me just say again that our needs, like we didn't come up with the models because we wanted to make models. We had needs that we wanted to address, and we did not find an easy way to address them, and hence low-cost simulation was the solution. And I think that someone who is working in another discipline will have totally different needs, and I encourage them to identify those needs and start experimenting.
Thank you very much. Since it is discipline-based, we have a lot of people from different disciplines from the attendee. Before I move to them, I want to ask Dr. Ahmed Alkhobrani if he want to share any low-cost model that he saw, either from your discipline as emergency or from others. Dr. Ahmed.
Yes, thank you very much. Yes, I think this is very important topics. We talked about it. And thank you, Dr. Zaher, for it's presented in clearest way. I'm also emergency physician working emergency for almost the same, but I'm in pediatric field. So I saw there is a models they're creating for, it's easy for like lumbar punctures for pediatrics, mannequins. This is almost the one I saw for its low cost simulations in comparison to one which it's commercials and done by the companies, which is very expensive, and also it is the same, it's leaking after multiple punctures. So yes, for you can do your mannequins and with low cost, and you can practice it on it more than one times instead of buying one of high fidelities mannequins. You do LBs more than one times and then it started leaking and lost your mannequins.
Thank you very much. Maybe I will ask also all people from the attendee, but let's move on with the presentation and we'll go back to this point. Dr. Mohammed, you can proceed.
Thank you, Dr. Abdullah. Like going the full circle and wrapping around, let's talk about some challenges that we're going to find with low-cost simulation versus commercial implementations. Number one, it's labor intensive. So if you're creating a recipe that has already been done before, just the labor of actually getting the materials and making it, and then maybe breaking it down or maintaining it is significant compared to commercial implementations. And if you're prototyping, or if you're doing something without a recipe, so you're kind of finding out what works or not, this is even more labor intensive, because it's going to require a lot of trial and error and modification and improvements to reach the end result that you want. Versus a commercial mannequin, where basically you have a contract with the company to come and repair it whenever something goes wrong with it. So it's easier, but again, for a significantly more expensive experience. And as we said, if you're prototyping, then there is a startup cost. So for example, it might cost you, let's say, a model might cost you 20 riyals to make, for example, okay? But it might cost you 200 riyals to prototype. So you're gonna get the equipment, you're gonna start finding out what material works and what doesn't. You're gonna like waste material because you're gonna build something and it doesn't work, and then you have to build it again. But once you reach that end result that you want, then you're gonna like find out the true cost of it, which is gonna be significantly less. So when you're starting up, it might be a little bit expensive, but on the longer term, it is definitely a better investment, or maybe 90% a better investment than getting something commercial. And if you're doing this, then this goes in direct conflict with most governmental purchasing strategies. So, for example, if you're trying to make something and it requires to purchase one sheet of a specific kind of leather, for example, or one bucket of silicone, or some gelatin, you're gonna purchase a small amount. And if you're doing this through your hospital, that is not the policy that usually goes. Usually you order, an organization orders large quantities. Usually they don't go directly to a shop and purchase from. No, they are gonna require different vendors to come and submit proposals, etc., etc. So if you're doing it through especially the MOH purchasing strategies, maybe it's going to be a little bit difficult. Maybe you're going to have to navigate the system and talk with your institution, talk with your internal resources, for example, to find out a pathway that kind of works for you with these kind of purchases that you're going to need to be making for prototyping, making models, and then maintaining them. We're back at where we started. So like this was an introduction to low-cost simulation. Where do you take it from there? You want to identify a need in your institution. So you might be working in a university, and you want to see which areas are your students least comfortable with, or which areas are they scoring the lowest on their licensing exams. Okay. If you're in a hospital, you want to check with your trainees, like what areas again are they less comfortable with, what M&Ms are you facing in the department because of performance issues, etc. You want to, in each specialty, in each training programs, you're going to find objectives, procedural objectives that your department needs, and you might want to start with the basic procedures that your entry trainees need to learn about, or the rarest procedures where your senior trainees are almost never exposed to. These different extremes are both good areas to start with. And as I said, each discipline or specialty is going to have a list of skills, especially hands-on skills where it would make a good starting point. And when you've identified the need, you want to try to come up with a low-cost solution. And I'm not going to provide like ready-made recipes, because again, as I said, each discipline has very different needs. But for most of what I have been doing is just searching on Google, searching on PubMed, searching on like other databases for other disciplines, for nursing, etc., and different simulation society websites. So the Society for Simulation in Healthcare has a low-cost interest groups where occasionally you'll be in contact with people that are going to be polishing models, etc. And you might find something, and you might not. And either way, you're going to decide what, depending on the recipe that you have, or if you didn't have a recipe starting from the grounds up, you're going to have to decide what level of fidelity or what features do you need. And that's going to go back to your objective. Even if you find the recipe with a very basic implementation, you might need to augment it to reach the fidelity that matches your objective. And the same goes, you might find an implementation that has way too much fidelity for the implementation that you need. So you're going to scale that implementation to the objectives that you have. And then you get to work. You create, you pilot, you obtain feedback, you show it to other people, other experts in that procedure or in that skill that you're trying to teach. And you let them do it and say, oh, this feels different in that way from the real patient, etc., etc. And then you continuously improve and augment until you reach a level of performance where the muscle memory that the learners develop when utilizing your device is going to be the same as a commercial device, and hopefully the same as what they're going to find with a real patient. So to summarize, low-cost simulation is an effective educational strategy. It is accessible through a variety of resources and feasible through a number of methods. And I've given you a taste of that world. I could be talking for hours about specific implementations, but I encourage you to look around, contact me if you have specific questions, even after the seminar, and I'm very happy to take your questions. Ustad Ajlan has a very good question, Dr. Abdullah, if you want to read it.
Yes. Dr. Ajlan, he was mentioning that, is that mean low-cost work with task trainers mostly or no?
So when you're talking about environments in general, so when you're doing simulation, you're making an environment, and most of the environment is most of the time it's a healthcare environment. So 90% of your lab is going to be stuff that you have from the hospital. So patient stretcher, crash cart, laryngoscopes, etc. So all of these usually are not involved in the cost because they're available in the hospital itself. You're not buying them specifically for the simulation. What's left is your mannequins, okay? And that could be a high fidelity mannequin. And again, while I have my reservations about the term high fidelity mannequin, but your SimMan 3G, for example, etc. Or it can be your task trainers. So essentially, these are the parts that you need to build either in a commercial setting, or like if you're getting things through a commercial setting or through a low-cost setting. The rest of the environment is easily recreatable in the hospital or in situ, and you do not usually need specific equipment for that. Saying that, if you're talking about another aspect, for example, the audiovisual side of running simulation scenarios, recording simulation scenarios, having a setup for debriefing. Actually, I have experience with working on low-cost alternatives for that. So, for example, building that audiovisual system can cost hundreds of thousands of riyals for a single room, but you can reduce that cost easily to about 3,000 to 4,000 riyals through purchasing specific set of equipment. But I'm not going to go towards that because it requires a little bit of knowledge in electricity, in computer science, in these interactions between the technologies itself. So I think it's a kind of a second step beyond creating models. But the model making itself answers about 90% of your simulation needs if you're trying to develop a simulation implementation in your institute.
Thank you very much, Dr. Mohammed. First of all, I would like to thank all the speakers and all participants who participate in this activity. Appreciate your efforts, appreciate your comments when you share the knowledge. I cannot see any more question. We still have 4 minutes for question. If you would like to ask any question either to Dr. Muhammad or Dr. Ahmed, or you have any point of view before we conclude at 8. Still we have 4 minutes. It's open for all. Dr. Abdelaziz? But I think Dr. Abdelaziz, I'm not sure he is not talking permitted yet. أستاذة صفاء ممكن تفتح المايك دكتور عبد العزيز؟ أظرف عبد العزيز. طيب فيما يفتح المايك لبروف بوكر, let's take other comments from other people.
Abdullah, if you allow me, I have a question for Dr. Muhammad.
تفضل.
Dr. Muhammad, when we need high cost or high fidelity simulation, if we are talking about low cost simulation, so is there is need for high fidelity simulations?
Thank you so much, Dr. Ahmed. This is a very complex question. So again, let's agree that low cost is not low fidelity. And let's go back to the objectives. If that low cost model or low cost environment does not address the objective that we want out of that simulation in a way that is satisfactory for the trainee performance in real practice, then we need a higher cost alternative. I think that's the concept of low cost is starting from the lowest cost that will get you the objective that you want. And in that sense, you almost never, like, here is the thing. I've seen a good number of simulation labs all over the country, and I'm sure that someone who's involved or can identify low-cost implementations, coupled with more flexible organizational purchasing strategies, can decrease the cost of starting and maintaining a simulation lab by 80, 70, 80% across the board. So I think it's that concept goes back to what is the objective that you're trying to implement.
It's clear. Thank you very much.
يعطيك العافية. أنا also I would like to ask maybe final question or from my side to Dr. Zaher. Now the pricing and the cost is going high in general. Simulation is part of it. Now the courses or it's getting a little bit higher prices than before. How we can tackle this in general? Is there any suggestion from your side about this? How we can, as a leaders in simulation, think about innovating, implementing new solutions to decrease the cost for people?
Thank you, Dr. Abdullah. I think an area that's rarely tackled is consumables. So even if people don't want to purchase or don't want to make task trainers in their institutes, I think a lot of the down the road costs for a simulation center is consumable. So for example, you're going to get a chest tube trainer or a surgical airway trainer, and you're going to purchase that package of skin for that simulator for a significantly high markup, even though this is made of silicone, which you can make in-house. And if you get the best quality silicone that gives you essentially the same or even better fidelity for the procedure, because you can kind of decide what flexibility, what tension, what stretchiness do you want in your product. If you can make it in-house, it's going to be cheaper than buying the consumables from the company directly. So I think that any simulation lab can benefit from that. And also repurposing existing simulators for users that are not on the label. Dr. Abdullah, you're muted.
It's okay, you can proceed, Dr. Mohammed.
Hey, so yeah, and the other part would be expanding the uses for simulation mannequins. So we're using the SimMan 3G to do scenarios, but there is no reason why we can't use the same mannequin, for example, to teach airway, to teach a procedure that was not, like, with very little modification. The SimMan 3G can be used for central venous access, for example, okay, or a similar high fidelity mannequin. It's as simple as making a vascular access model, making a place for it in the mannequin, and then utilizing that mannequin, and then you've actually increased the fidelity of an already a very high price mannequin. You've made more use of it.
طيب يعطيك العافية. We will conclude this seminar with the last comment from Prof. Abdelaziz. You can talk to Prof. Abdelaziz from my mic.
يديكم العافية. شكرا جزيلا. Thank you very much, both speakers, Dr. Marshad. It was a really great seminar, and I think all of us will have a lot of thoughts out of this. I really appreciate that. I would just echo two more important two points mentioned many times by the two great speakers today, that let's all remember simulation is always a mean, not a goal. So whatever we want to do in simulation, remember that we want learning to happen, and we could always come up with solutions. I remember we used role play a lot, and we published papers. It's a great point to develop new ideas and to implement, experiment, and publish and take awards with. Also, chicken breasts, water, a lot of crazy ideas transfer into a lot of fun, education, challenges, chicken breast for regional anesthesia, needling, teaching, meats. We use anal cows or rectums for pelvic floor surgery. Lots of great ideas. Sometimes it's crazy ideas, but it's a lot of innovation. Thank you very much. And thanks for the whole team who made this seminars successful. Thank you very much.
يعطيكم العافية جميعا. أنا ما أبغى I know the time is finished, but feel free to leave. But Dr. Nada added one question. I would like to ask our speaker to answer it. Maybe Dr. Ahmed Alkhobrani. Dr. Nada mentioned that I have question regarding introducing new scenarios, ideas in simulation environment. I don't take real attention in both simulation and real practice, which produce gap in practice. Example of such scenario incorporating and cases with people with disability or children with disabilities or infant with congenital anomaly, for example, newborn with cleft palate. So what I understand from you, Nada, that you are suggesting to add or incorporating new gaps. Is that right, Dr. Nada? Feel free to open your mic.
Yes, assalamu alaikum wa rahmatullahi wa barakatuh. Sorry, I'm late and for this question, but I was waiting for everyone to finish. Actually, I want just to actually this idea, it's really stuck in my mind, and how to incorporate this people with disabilities in simulation environment and exposing our students to that, because really it's produce a huge gap. And we noticed that some students, when they practice and then they face patients, for example, in emergency or whatever, they really facing a huge difficulty if this patient has some disabilities. So just I'm thinking how that will be introduced and or incorporated in the curriculum in the simulation environment or in the scenario.
So this question is open for all.
Yes.
Dr. Ahmed, Dr. Mohammed, if you would like to answer.
Yes, so thank you, Dr. Nanda, for your questions. Yes, so yes, this is a very important aspect in the pediatric, which is disability and congenital anomalies. And as we mentioned, so each scenario, it has its own goals and own objectives. What is the goal and objectives? So if your goals for these scenarios is like communication with such patient, or how to manage this patient in certain aspect, like patient with like cleft palate, how to do with airway or how to intubate it. So you set your objectives, and based on that, and also you write your critical actions. So what if it is go for like patient with cleft palate and he's going for direct laryngoscopes and it is failed. So what he is backups, what he has backups, and did he is think about he is anticipating this patient will be difficult, and he need like ENT or anesthesia to be around during the intubation for this patient. So what you need from this aspect is you need to be put it in the scenarios. I think, is this answering your question, Dr. Nada?
Yes, thank you. Just I have for confirming this about the scenario, do we have to test this scenario first and then apply it to in the simulation environment within the the student's practice? For example, such as the pilot testing like that, or I can do it immediately? What is the process?
Yes. So yes, it's testing the scenarios as mentioned by my my colleague, Dr. Mohammed. Yes, it's very essential for each scenarios. And before you testing with a colleague, you need to test with your groups and do rehearsal with the scenarios, with the same tech, and with instructor with use, and with any facilitators and standardized patient. So you need to come over the tables and to see, this is our scenario, this is our step, we'll go through it, what we are prepared, what we have missed to do. And then you run the scenarios. So you will be all on the same page, and you all the thinking about the same scenario. So you discover what you will be missed. And then you will go to test with another colleague or with one expert in the field.
يعطيكم العافية. Thank you all for attending and staying with us till this time. For people who ask about CME, yes, there is CME for all SSH member who attended the whole program. Also for people who registered and they pay the CME cost if they are not a member. Thank you all. Appreciate your attendance and participation. يعطيكم العافية جميعا.